We're going to try and stick to time because we have to be out of this room by 4 o'clock. Something awful happens to it, apparently. I'm not sure, but no, we have to be out by 4. And so, but we've got time to go through, so we can do lots and lots of chatting afterwards. So we'll be quite precious here, really just because of the 4 o'clock deadline, and then we can go out. I'm just going to embarrass a couple of people, actually, before we start again. Flo and Ali, who are at the back, who don't want to be mentioned, have worked phenomenally hard. And I think if I ended right at the end to say thank you, then you don't appreciate what they've done. And I naively thought when you go to a conference, you just have a laptop, you plug into something, and then it's done. But when you realise what good lighting, good sound, good equipment is, this is what you get. So the guys at the back have known Ali for a long time. She's really, I don't know what she's done to persuade them to come to Stratford. But I'm just really grateful because those little things, you know, the sound, the quality have been phenomenal. So can we just give a big round of applause to them? So that wasn't on the programme, so I'm going to get into trouble. But anyway, this next session, I'm going to say every session obviously is really important. This session is really important. When I was at medical school, 1 in 12 women had breast cancer. When I qualified, it was 1 in 11. It's now 1 in 7. HRT prescribing has really reduced since I was in medical school in the 90s. So if every case of breast cancer was due to HRT, we would have seen a reduction. Of course, we know there are other risk factors for breast cancer. I actually wanted to be an oncologist. Some people know that, some people don't, but there you go. I wanted to be an oncologist. And I only changed, actually, because I really interested in medicine, really interested in disease, and I did an oncology job when I came back from New Zealand, and I worked with Hannah Ward's husband, Chris, with no connection at the time, and we both found it really distressing, actually, because we found that people were sort of overtreated. There were people that were coming in for another trial of chemotherapy, and we were thinking maybe a diamorphine pump might have been a bit more appropriate, and let them have a comfortable death rather than sort of this like, let's try it as much as we can to make sure there's no cancer, there's no recurrence. And it sort of haunted me a bit, thinking we've got to look at the whole picture. So anyway, obviously I changed my career, but I did a project with Tony Howe, a professor in Manchester many years ago. And it was looking about what people, actually my remit was to write something about tamoxifen, because there was no internet then. I'm quite old. So there was no internet. People weren't told any information. It was very paternalistic medicine. And so I was asked to write about tamoxifen. And I interviewed a few women to ask them what they knew about tamoxifen, and they didn't. So then I asked them, do you know what breast cancer is? Do you know what cancer is? They went, it means death. I said, oh, right, well, it doesn't actually. I said, what about, you've had chemotherapy, you've had radiotherapy. What does chemotherapy mean? They said hair loss, vomiting. Right. So I went back to Tony and I said, look, I can't just write about tamoxifen. I'm going to have to write about what is cancer, what is chemotherapy, what is radiotherapy. And then we wrote about tamoxifen. And I've always thought, as a medical writer, there's so much that patients don't understand. And as doctors, we've got this power that we can just tell them things, and often they will do it. Things have really changed. Obviously, shared decision-making is really important, but somehow breast cancer patients still often, it's all about the breast. It's all about no recurrence, no metastatic disease. Obviously, no one wants to die from breast cancer, but most women who've had breast cancer don't die from their disease, thankfully. And I now, obviously, all I do is think about menopause and perimenopause, worry about these 1 in 7 women who would just fall off a cliff after their diagnosis often. So this session's really crucial. So I'm very grateful for Bev, who's going to come to the stage. Come. So Bev is a patient. She doesn't mind me breaking confidentiality, do you, to say? So Bev is one of my first patients. So 7 years ago, if you can imagine, menopause wasn't really spoken about very much. I was doing my clinic 1 day a week in a private hospital to try and get some of my friends off antidepressants. And then I started to get people coming who I didn't know, who came from different places. And then Bev came one day to see me. And you'd been struggling for more than just a few years, hadn't you?
11 years after breast cancer. So, 11 years with the menopause, yes. But sort of breast cancer at 43.
Yeah. So how old were you when I saw you?
I was 57, so...
So 57,
yeah.
And she'd had 11 years of symptoms.
Yes.
And you tell me about some of the symptoms.
Hot flushes, night sweats, tiredness. I couldn't sleep at night. It affected my work. I used to go and stand in the walk-in freezer at work just to cool down and and I just didn't want to go out at all. I just didn't want to do anything. So.
And you're not really a shy, retiring person.
No, I'm not. Not at all. Not at all.
But I mean, a lot of people, so vasomotor symptoms, as you know, isn't the most common symptom, but you were dripping in sweat, weren't you?
Yeah, I'd just be standing here and I could feel it's like someone switching a fire on, and the heat would come up and then the sweat would come down, and it was just horrible. I just didn't want to go out and just didn't want to work.
And you wore black, didn't you?
Just wore black so it wouldn't, sweat marks wouldn't show. I kept my hair really short. I still do, but kept my hair really short because it was just like I'd been in a swimming pool or a shower. It was just horrible. Just horrible.
And you weren't really exercising or doing much?
No, not at all, no.
Yeah. So we took this history all about the symptoms. So she did the symptom questionnaire, lots and lots of severe. So before she came in, because I was on my own, I didn't have a history in before. All I had was the symptom questionnaire. So I thought, well, she'll be lovely and satisfying to treat. She's got all these symptoms. And then I just went through anything in your past history, had any illnesses or diseases, and you said...
Yes, ectopic pregnancy, full hysterectomy, precancerous cells, breast cancer. It was about this long, the list, and I said, can you help?
Yeah, so when she said hysterectomy, I thought, well, that's easy then. So not worried about her endometrium. And then she said breast cancer, and I looked at her, and I just thought, I've never, ever treated anyone with HRT who's had breast cancer before, but I also looked at her, and her quality of life was just practically non-existent. I was on my own, so I couldn't go running to Rebecca and say, well, what would you do? I didn't have anyone. So I sat there and said, well, there is a treatment, and but we don't know what the risk is for the breast cancer that you had in the past. I remember feeling really uncomfortable. I don't know if you sensed how uncomfortable I was in the consultation.
Yeah, I think it was like... a bit nervous. I think you were a bit nervous, and it's like you were desperate to help me because I was in a desperate place. So it was like, oh well, do I do this or do I do that?
Yes.
Yeah.
And I'm a very open, honest person, and I wasn't going to share that I wasn't nervous. So we had this discussion, and all you needed was the gel at the time.
Yeah.
So, well, you decided gel rather than patch. There's no way patch would stick onto your skin at all because you were sweating so much. So I said, well, take the gel. And it's reversible. If you stop using it, it'll be out of your body the next day. You're in control of it. You can start with half a pump, start very low, see how you go. It gave you some information. We had lots of discussion, didn't we?
Yes.
And then you went off. And then I didn't sleep for ages.
I did.
And I lay there thinking, what have I done? I'm going to get reported to GMC. I'm going to be struck off. I kept saying to my husband, well, this is awful, awful. He said, well, did you share to the surgeoncy? I said, yeah, of course I did. But even when I look at the evidence, it's not really there. And there's no guidelines. And the guidelines say, well, you can in extreme circumstances, but was she extreme? Maybe I should have let her suffer a bit more, but, I don't know. So I really, really struggled, actually, for that time, because I felt very exposed on my own. And so anyway, 3 months later, you came back, and I thought, oh no, she's come back. What's going to happen?
Am I going to sue you? No.
I wasn't worried about that. I wasn't worried about being sued, because if you worry about suing, I don't think you'll ever do anything in medicine. I was more worried about somebody else. It's all ironic with what's going on at the minute, but someone else reading your records and thinking that I was a charlatan doctor who hadn't done things properly. That was my biggest concern. Like, what would my contemporaries, what would my peers think that I've worked? And I was a private doctor. I wasn't protected by the NHS. I felt very, very exposed. I'd also in the background been reported by one of the gynecologists to the NMC for saying that I wasn't experienced enough to run a menopause clinic, which obviously that was fine. Nothing came of that. But there was all this, oh gosh, this is now really out of my boundary. So you came back and you look quite happy. So what did you do?
Top of the world. It was like within 2.5 weeks, all the hot sweats, all the hot flushes, I was normal. It was like I was functioning. Oh, yeah, give me some more. Yeah, it's the best thing that's ever happened to me the last 6 years. Yeah, I'm much healthier, much better in my life, and
yeah.
Yeah, it's all good. I just, it's positive. And there's still this taboo about breast cancer and HRT. And I just think, I remember you saying, well, the risk is you could go out here and get run over by a bus. There are so many more benefits of taking HRT. So I was willing to, after 11 years of suffering, take that risk. And I'm so glad I did.
Yeah, and I think there's a couple of things that I really learned. Obviously, every day, I'm sure you agree, learn from patients. So learn from science, learn from evidence, but also really learn from patients. One of the things that really surprised me is that you'd had symptoms for so long, yet 2.5 weeks was better. I've been to so many talks at menopause conferences talking about the placebo effect. There's a placebo effect in everything we do, but to be so quick, to be so dramatic, I don't think, no disrespect to your mind, I don't think it was just placebo in your brain. So just that reassurance actually that starting people who have had many years since their menopause started made me think, well, not just for people who've had breast cancer, but others, there might be benefits, and we've seen that quite a lot with patients, so that was really reassuring. But the fact was also, when you came back in, I remember documenting that you'd lost weight, you were exercising, your lifestyle had changed quite quickly in 3 months, hadn't it?
It did, yeah. I just got so much more energy, and I actually felt that I wanted to live, and I wanted to do things, and I wanted to, carry on with life, and it's given me a lot more confidence. And it was quite interesting with the mental health thing this morning, and I didn't realise till I looked at it how I didn't have any confidence. I mean, 5 years or 6 years ago, I wouldn't have stood on this stage now, and I just feel so much better in myself. And it's the whole package. And
and that is so important. I mean, I'm really jealous when I see Bev in consultations because she always tells me about which holiday she's been on, where she's gone. Do you want me to mention that?
Yes, carry on.
Do you know? I'll leave it to you.
No, we have a laugh because I've been married and divorced 3 times, and she'll say, right, who's the next one? And it's like and I'm always like, well, I'm doing this and I'm doing that, or I've met this or I've done that, and it's like, I'm full of beans really, aren't I? So you have to shut me up sometimes, don't you?
But isn't that wonderful? And we've got evidence, I'm sure Tony will agree, that people that exercise have less risk of recurrence from breast cancer, people who sleep better, people who are happier. There's all these other things as well that's really, really important. And, you're a consenting adult, you know that there are risks, but actually for you, the benefits are really important and not insignificant. And so from Bev, I'm very grateful for lots of reasons for meeting you, Bev, but it really sparked this interest. And the more the clinics got busier, the more we've seen people who've had breast cancer. And a lot of physicians and clinicians who start with us are very nervous about seeing, understandably, like I was, seeing people who've had breast cancer. But I've found with my clinical experience, they are the most rewarding people to treat. They're the most horrific stories that I hear from women who tell me that they really can't sleep. I've seen lots of women who've had urosepsis many times just from their vaginal symptoms. No one's given them vaginal hormones. That they say, I want to live, I don't want to exist. Lots of women say, even if I had to go through with another mastectomy, chemotherapy, radiotherapy, I would do that again if it meant I could sleep a night, if I could talk to my partner, I could go on holiday. And so I think as doctors, we're not paternalistic. I really feel that I am more of an advocate for patients. I don't live their lives. I don't know what it's like to stand in a fridge at work to cool down. And I feel that very strongly, it's so easy when you read a clinical study or you read some guidelines or you read a consensus statement, what we should and shouldn't be doing. But rules are sort of there and guidelines are there, but actually it's very different. Every patient's different. I've also seen quite a few patients who have been every day worried about recurrence, and that's the thing that keeps them awake at night. Those women I wouldn't really talk about HRT to unless they wanted it, because any risk is just too much for them. Whereas other people, we see a lot of women who are more worried about osteoporosis. They're more worried about their long-term, health. And the longer it is without, since the diagnosis was, the better the prognosis is, as you know, and the more likely you're going to get a heart attack or something else. So it's looking at that bigger picture. So I just thought it's really useful. I've been to so many medical conferences where it's all about the data and the stats, and we forget that it's about real patients.
Person.
That's what we do.
About normal.
No, I don't know about that, but about real people. So I'm just want you to all just say a big thank you to Bev, because it's a lot of confidence to come. Thank you.
Thank you, darling.
So since I've been thinking more about the evidence and the lack of evidence, actually, I've read a lot of papers, a lot of detail, but my brain's quite full and cluttered. So I was very grateful and pleased when I met Sarah Glynne, who's phenomenally clever and got a very scientific background as well. And so we've been working behind the scenes for far too long, Sarah will tell you what, to develop some consensus statements actually based on the evidence and lack of evidence as well for women who've had breast cancer. So Sarah's going to talk very quickly. Is that a fair thing to say? There's a lot of information she's going to get through. Normally I would say to Sarah, just slow down and talk a bit slower, but I'm actually quite happy that she's talking quickly because we're short of time. There's a lot of information. You'll get a copy of the slides at the end, and it will probably deal with more discussion that we'll have time for as well, but we can carry on discussing out. So very grateful to Sarah for coming today, so thank you.
Seems to be working. Good. So hi everybody, I'm Dr Sarah Glynne, GP menopause specialist, and I'm here today to talk about the evidence regarding breast cancer and menopause, with a specific focus obviously on HRT because that's the difficult bit, and it's a big topic. So I've prepared 3 case histories and I'm going to really scoot through them quite quickly, but I'm very happy to take questions at the end. When it comes to breast cancer and menopause, there are 2 relevant guidelines really. The first is this one, the NICE breast cancer guideline that was first published in 2009, that tells us that we shouldn't be prescribing HRT for any woman after breast cancer other than in exceptional circumstances, which it doesn't define. And then in 2021, NICE produced this guideline regarding shared decision making, which tells us that we should be involving patients in decisions about their care by providing them with information about all the available treatment options and enabling them to make an informed decision that factors in their views and preferences and treatment goals. So to my mind, these 2 guidelines are very contradictory because on the one hand, we're being told essentially not to prescribe HRT after breast cancer. And on the other hand, we're being told to involve patients in the decision-making process. And of course, the best treatment for symptoms due to hormone deficiency is hormone replacement therapy. So how can we be counselling these patients effectively if we're not giving them all the information? And many of you will have seen this slide before. It's from a survey that Sarah Ball did last year that she presented at the International Menopause Society conference. And we know that many women who are often struggling with severe, sometimes debilitating menopausal symptoms often really struggle to access good quality menopause care or any menopause care after breast cancer. And when it comes to HRT, more often than not, it's just a flat out no. And 2/3 of patients in this survey felt either relatively or completely uninvolved in decisions about their menopause-related health after breast cancer. I'm not talking about non-hormonal treatment options today. It's obviously also important and has a place. This is just a reference for you. It's a useful summary with dosing information, etc., if you want to have something to keep in your office. So the first case history is a 56-year-old author and journalist who had left-sided DCIS diagnosed in 2010 at the age of 43. It was a 52mm grade 3 ER negative, PR negative, HER2 positive. These are the letters the patients get, by the way. So if you find this nomenclature confusing, imagine what it's like for the patients. With 1 involved lymph node. Now, the eagle-eyed amongst you will have already spotted there's a problem. DCIS is non-invasive. It's by definition, it's disease that's confined to the milk ducts and it does not spread. It's usually, it has an excellent prognosis. Even without treatment, only about 1% per year will progress to invasive breast cancer. With treatment, it's curable. It's not possible to have DCIS with disease that spread to the lymph node. So this lady had been misdiagnosed with DCIS when, in fact, obviously what she had was early invasive breast cancer. And I'm just drawing your attention to that because I think when you are counselling women women who've had large DCIS lesions, it's very important to realise that it's very easy to miss foci of invasive disease. I was talking about this with someone recently, actually, who'd thankfully done the maths for me. And if someone's got a 4-centimetre diameter lesion, for example, then you would need something like 85,000 slides, because each section is 1 by 1 centimetre square and just 1 micrometer thick. And to prepare 85,000 slides would take 5 or 6 years. So clearly that's not feasible in clinical practice. And what we do is we select maybe 10, 20 slides. And so you're looking at a tiny percentage of the tumour. And especially in someone with high-grade disease, it's really easy to miss foci of invasive disease. So she didn't have DCIS, she'd had early ER-negative breast cancer. So she'd had a left quadrantectomy, axillary node clearance, CT is chemotherapy, and she was treated with Herceptin. Also of note in her history, she's got a high cholesterol on atorvastatin and a family history of ischemic heart disease. Her mother had had an MI at the age of 56, survived and gone on to develop Lewy body dementia at the age of 70. She'd been premenopausal when she was diagnosed with DCIS, but her period stopped after chemotherapy, which is not unusual. And she tells me that she transitioned through the menopause quite smoothly at that time. But in January of this year, she'd attended her GP surgery for a smear test, and the procedure had to be abandoned because it was too painful and uncomfortable for her. And then she'd had a conversation, I think, with her GP, and had come to see me for a menopause consultation to see whether she might benefit from HRT or not. And on direct questioning, when I asked her, she actually reported fatigue, brain fog, insomnia, low mood, no libido, genitourinary symptoms, and weight gain. So she had lots of menopausal symptoms. And when it comes to ER-negative breast cancer, the data is very limited. There have only been 2 studies that have attempted to stratify the risk according to the hormone receptor status, and neither of them was sufficiently powered to enable us to draw any firm conclusions. But what we do know is that we have very good randomised control evidence regarding that these women do not benefit from endocrine therapy, and they're not offered endocrine therapy. Not surprising, they don't have hormone receptors, it's not going to make any difference. And therefore, intuitively, HRT is unlikely to worsen the prognosis in these women. It seems nonsensical, to deny all women breast cancer, even when they've had a history of estrogen receptor negative disease. So broadly speaking, we think that for most women with ER-negative disease, the benefits are likely to outweigh the risks if they choose to have HRT. The one caveat is that you have to be aware there's a small risk that in the event of a recurrence, it may come back as ER positive. So obviously the risk will depend on the risk of recurrence in the first place, which is going to depend on the background risk. We'll talk a bit more about that shortly. But if someone is at risk of recurrence, roughly 1 in 50 women with a history of ER-negative disease will have an ER-positive secondary tumour. So it's just something to be aware of. It's going to be important for some women, maybe not so much for others. So this is what I did, gave her vaginal hormones. As Louise alluded to earlier, vaginal hormones, very safe after any type of breast cancer, really. Absorption is minimal stroke negligible. She wanted some estrogen and some progesterone. We talked about testosterone, and she's going to come back in 3 months and see how she gets on. So the second case history is a 59-year-old housewife who was diagnosed with a right-sided invasive ductal carcinoma in 2017 at the age of 53. It was a small 15-millimetre, low-grade, grade 2, estrogen receptor positive, HER2 negative tumour with disease, again, in 1 lymph node. She was treated with a wide local excision, radiotherapy. She'd had letrozole for 5 years, and she'd finished treatment in January of this year. Of note, she's also got osteopenia and, again, a family history of ischemic heart disease. Her last menstrual period was at the age of 48, so she was postmenopausal when she started her letrozole. But almost as soon as she started her letrozole, she got a whole host of menopausal symptoms, of which insomnia was the most debilitating. And she tried everything, melatonin, sopiclone, nitol, etc., and nothing had helped her insomnia. And because she couldn't sleep, she was exhausted, she had severe brain fog, she had low mood, was suffering from anxiety, panic attacks, also had hot flushes, joint pains, and tinnitus. So at this point, in someone with a history of estrogen receptor positive disease, I'd start talking probably about this article that was published in the Cancer Journal last year by Avram Blooming, who's an oncologist in the States. And if you haven't read this article, it is worth reading. In short, between 1980 and 2013, there were only 25 primary studies have ever looked at breast cancer outcomes in women who've taken HRT after breast cancer. And of those 25 studies, 24 have demonstrated no increased risk of recurrence or breast cancer death. In fact, 5 reported fewer breast cancer events and 4 reported decreased mortality. Only one study, which was the HABITS trial, reported an increased risk of recurrence in women who took HRT after breast cancer, but not breast cancer death. And you'll notice that the confidence interval there includes 1. So overall, that's very reassuring, I think. The problem is the data is very limited. The studies are of variable, often poor quality, and they are too short and too small for us to be able to draw any firm conclusions from that. I will say that the risk of recurrence is highest soon after diagnosis. So even though these studies were small, a median duration there of 2.5 years, even though they were small, you would think that if HRT was harmful, something might be flagging up. So this is not definitive, it's not conclusive, but I do think it's reassuring. Clearly, we need more research. This is hot off the press. So this is a really interesting study that was published in the New England Journal of Medicine just earlier this month. And it looked at young women, median age of 37 years, who have a slightly worse prognosis with breast cancer. And they'd all been diagnosed with estrogen receptor positive breast cancer, early breast cancer. They'd all taken their endocrine treatment for between 18 and 30 months. And then they decided to stop their endocrine treatment because they wanted to get pregnant. And they were allowed to pause therapy for up to 2 years. And the investigators followed women up for about 3.5 years. And in that time, 3/4 of those women got pregnant. 365 babies were born. And if you look at the graph on the right, it shows you that there was no significant difference in breast cancer events between the women who chose to get pregnant and the women who didn't. In fact, the event rate was slightly higher in the control group, although it didn't reach statistical significance. And I think that's quite extraordinary. Again, it's a short duration. It's only 3.5 years. But remember, the risk of recurrence is highest early on after diagnosis. And these were premenopausal women who not only stopped their endocrine treatment, so allowed their estradiol levels to normalize in the normal physiological range, but they then went on to get pregnant, some of them more than once. And pregnancy is associated with a really significant rise, up to 20-fold rise in circulating estrogen levels. By the second trimester, it can be up as high as 50,000, and it stays at that level until the baby is born. So these women, early after diagnosis, they had very high estradiol levels. Again, it's not conclusive. You'd expect something to flag up, and it hasn't. So then I focus my attention quite often on the endocrine treatment, and this patient, as I've already said, had letrozole for 5 years. We've got good randomized controlled data. We know that taking an anti-estrogen drug, letrozole, which works by suppressing women's estrogen very thoroughly, taking it for 5 years reduces breast cancer mortality at 10 years by 40%. Which sounds quite impressive. But the question is, what does that mean for the patient? We should never really talk to our patients in terms of relative risk because it's not that helpful. It always depends on what your background risk is in the first place. So many of you have probably seen this. It's the Predict online decision-making tool. I'm sure some of you have used it in your consultations. It's a means of you plug in the patient's individual data, and then it calculates a risk with and without, a benefit with and without endocrine treatment. So I've plugged in all my patients' details there, and this is the first chart. This is my preferred graphic. I find this one the easiest to understand. And if you had 100 women in a room who were the same age as my patient with the same tumour, then over 10 years, 11 of them will die from breast cancer. If those same 100 women all take letrozole for 5 years, that's the difference. It's 3 women. So the other 97 women, exactly like that patient, have taken letrozole for 5 years and they haven't benefited from it. Either because they've died despite the letrozole because it only reduces recurrence by 40%, or they've died of an unrelated cause because unfortunately some of us will die of other reasons, or 84 women have survived whether they took treatment or not. It made no difference to them. So the survival benefit for this patient is 3%. Now, of course, some women will think, well, 3%, that's really good. I'll take that, thank you. Whereas other women will think, well, hold on a minute. I've got terrible side effects. My quality of life is absolutely rubbish. That's not worthwhile. Why am I even taking it in the first place? I've had patients get quite upset in consultations, actually, when they've realised that the gain they've got from their letrozole may be 1%, 2%, 3%, and nobody's explained that to them before. They thought they were preventing their breast cancer from coming back. This is an interesting study. They interviewed women who'd had breast cancer about what would they consider worthwhile from their endocrine treatment. And 1 in 3 women consider a 5-year survival benefit of just 1% worthwhile. So they'll take the endocrine treatment regardless of the cost. These women are not going to want HRT under any circumstances. They're not going to come to your menopause clinic, and you probably won't be talking to them. But just over a half of women required gains of at least 5% at 3 years, 5% or 3 years extended life. And 1 in 6 women required gains of 15%. I mean, that's quite high, I think. And unsurprisingly, the women who had more side effects and more severe side effects were more likely to require a bigger gain to make their endocrine treatment worthwhile. So what are the toxicities associated with aromatase inhibitors? Well, clearly, as this patient did, they can present with any type of menopausal symptom. Aromatase inhibitors are particularly associated with genitourinary symptoms and muscle and joint aches and pains, and they can be debilitating. Not surprisingly, if you take away someone's estrogen, you increase their risk of osteoporosis, which is twice as common in breast cancer survivors, and cardiovascular mortality is also twice as common in women who are using aromatase inhibitors. This is an interesting longitudinal study of 50,000 women with very early invasive ER-positive breast cancer. T1A means the tumour was less than 5 millimetres, so really excellent prognosis associated with this type of cancer. And over 10 years, women over 50, they were 5 times more likely to die from something else than they were to die from their breast cancer. In the younger women, they're still more likely to die from breast cancer. That reflects in part absence of competing risks, because usually they're otherwise healthy, but also younger women are treated differently, as we shall see. There have been a few studies like this one, the Long Island breast cancer study, that looked at all-cause mortality after a breast cancer diagnosis. And if you look first at the graph on the left, you will see that women with breast cancer have higher all-cause mortality from diagnosis onwards. And by 15 years out from diagnosis, women with breast cancer are twice as likely to have died compared with women in the background population who didn't have breast cancer. But the cause of death changes after diagnosis. So not surprisingly, early on, unfortunately, some women will die from breast cancer, and their risk is highest in the first 5 years, maybe up to 10 years after diagnosis. What the graph on the right shows you is that from around 7 years, the cause of death changes. So at that point, cardiovascular mortality starts to increase and exceeds that of the background population. So again, by the time you're 15 years out from diagnosis, you're almost twice as likely to have died of a cardiovascular event compared with someone who hasn't had breast cancer. Nothing to do with the breast cancer, not directly. And we know about this. So this data is taken from the American Heart Association consensus statement that was published in 2021. They compared tamoxifen with aromatase inhibitors. Grey means there's no significant difference. Red means there's an increased risk, and the size of the triangle or the rectangle is proportional to the degree of the risk. And if you're using a SERM, such as tamoxifen, then your risk of having a blood clot is much higher. But if you look on the right-hand side, those women using aromatase inhibitors, they're at a higher event of all cardiovascular risks, so cardiovascular death generally, MIs, heart failure, hypertension, arrhythmias, etc. And really, it's not surprising. We've known about this for a long time. If you take away women's estrogen, you increase their cardiovascular risk. This data is taken from the Framingham study. It was published in 1976, and it shows that at any given age, women who are postmenopausal are at higher cardiovascular risk compared with women who are premenopausal. And the earlier you transition through the menopause, the higher your risk. It's not surprising if you treat someone with aromatase inhibitor for 5 years, or in some cases up to 10 years, you are going going to significantly increase their risk of cardiovascular disease. It's not rocket science. And that led the authors of this study that I showed you, the Long Island study, to conclude that this current paradigm that suggests survivorship 5 years after diagnosis is a meaningful threshold doesn't account for the substantial increase in risk of non-cancer related death that occurs after this point. So it's emphasizing the effects of treatment and sort of focusing very much on the breast and thinking, forgetting to think about the bigger picture and what else might be going on, and heart health and brain health and bone health and so forth. So what about the benefits of HRT? Well, I'm sure I don't need to tell you that the most effective treatment for symptoms of hormone deficiency is hormone replacement. And not only that, but in cancer-free women, certainly HRT has lots of long-term health benefits. It halves risk of ischemic heart disease, coronary heart disease. If you give women their hormones back, their cardiovascular risk goes down. Diabetes by 30%, osteoporosis by 40%. We don't have good data in breast cancer survivors. Clearly, the small number of studies that have been undertaken so far have very much focused on the risks. None of them have looked at the possible benefits, and certainly none of them have looked at long-term benefits. But intuitively, it seems likely that women with a history of breast cancer are going to benefit in the same way. So in summary, then you're bringing it back to the patient. Taking away her hormones for this patient was associated with a 3% survival benefit, okay? Presumably, and this is not an exact science, but presumably allowing her to have her hormones. So if she'd been premenopausal and she decided to stop the letrozole, if she's postmenopausal and decides to have hormone replacement, is associated with something in the region of a 3% loss of survival benefit or a 3% increase in risk. I don't know that for certain. I can't quantify it. There's no data. Possibly I'm underestimating the risk. You know, postmenopausal women don't normally have high estrogen levels. If there's a dose-response relationship, I don't know if there is, then theoretically the risk might be slightly higher. But equally, the risk might be lower. LTED stands for long-term estrogen deprived. And we know that for some women, after 5 years of estrogen deprivation, so either because they've taken endocrine treatment for 5 years or they've been through natural menopause, estrogen can have the opposite effect, and it will stimulate breast cancer cell apoptosis and tumour regression. It's probably why estrogen used to be used to treat breast cancer in the 70s before tamoxifen came along, and it only worked in postmenopausal women, not premenopausal women. And it may underlie the reduced incidence of breast cancer that was observed in the WHI study in women who were age 63 and, you know, roughly 10 years postmenopause. So, and of course, we can't quantify and factor in other effects, you know, cardiovascular mortality, etc. So it comes down to counselling the patient, saying, look, this is what I think. I think your risk is low. I think there's very limited data. You know, you have to share the uncertainty. I absolutely cannot guarantee safety. But I think the risk is small. It comes down to the risk-benefit profile and patient choice, and let patients decide what they want to do. And this patient, we tried a few things. She was very keen to have all 3 hormones. So we've started Evorel, Utrogestan and Testosterone, and we'll see how she gets on. So I've got one more case history. It's just a different example. This is a 51-year-old artist with 3 children between 12 and 17. And she was diagnosed with left-sided cancer, ER-positive cancer in 2019. And she had, if it's possible to have such a thing, she had a lovely tumour. It was small, low grade, and localised to the breast. So very treatable. She had a wide local excision with radiotherapy, took tamoxifen for 3 years and had already stopped it before she came to see me because she couldn't tolerate the side effects. She already has borderline osteopenia, and she also has a family history of ischemic heart disease. And she had a long list of menopausal symptoms as well, 0 quality of life, wasn't having sex with her husband, and was, you know, quite desperate actually by the time she came to see me. So tamoxifen works differently to aromatase inhibitors. Aromatase inhibitors, as I've already said, they suppress estrogen production, and women who are using an aromatase inhibitor have very low estrogen levels. Tamoxifen is a SERM, and it doesn't do that. So most premenopausal women who are using tamoxifen will actually have normal to high circulating estrogen levels. For that reason, possibly, it's slightly less effective than aromatase inhibitor. Taking tamoxifen for 5 years reduces 10-year breast cancer mortality by about 1/3, but they're often better tolerated. So I've met some patients who are taking tamoxifen and don't have any side effects. I've also met other patients like this one that has lots of side effects. It's more variable, and the long-term health risks associated with tamoxifen are different. Back to PREDICT, I use this in every breast cancer consultation. And again, when I plugged in her numbers, actually the survival benefit at 10 years was about 3%, so very similar to the previous patient. The other 97 women who would have taken tamoxifen wouldn't have benefited from it. Now, some people would think that worthwhile. Clearly, my patient didn't, because she'd already stopped the tamoxifen before she came to see me. So in terms of toxicities, again, any menopausal symptom, tamoxifen is also associated with a small increased risk of blood clots. It's 5 additional cases per 1,000 women who use tamoxifen for 5 years. It's associated with a small increased risk of endometrial cancer, 4 additional cases. I've been told, I don't have a reference for this, but I've been told that for every 80 lives saved from breast cancer, tamoxifen causes 1 endometrial cancer death. I need to try and find that reference. Cataracts, 26 additional cases of cataracts per 1,000 women. It's obviously not life-threatening, but I think that's quite important to know about. You know, she's got 3 young kids. These women who are being treated with tamoxifen are young. I wouldn't want to get cataracts and, go blind. But it doesn't increase risk of ischemic heart disease. In postmenopausal women, it doesn't increase fracture risk. In premenopausal women, data is conflicting. NICE thinks it doesn't. I think it probably does reduce bone mineral density, but that's another talk. Very brief, don't worry about this slide too much. I just wanted to prove to you that women, premenopausal women who are using tamoxifen have normal to high circulating estrogen. So the numbers I've circled are the median estradiol levels in a group of patients who are using tamoxifen. And 90% of those women had estradiol levels between 200 and 1,000, or just over 1,000. And about 1/3 of them had normal or near normal menstrual cycles. So it doesn't take away your estrogen. Therefore, interestingly, in early trials have suggested that the benefits of tamoxifen are similar irrespective of age or menopausal status. So it doesn't matter if you're young and you've got estrogen, or if you're older and you don't, the benefits are the same. It doesn't compromise the anti-tumour action of tamoxifen. And therefore, presumably, adding a small amount of estrogen is unlikely to be of consequence in postmenopausal women who are taking tamoxifen. So it could be a really nice option. And in fact, quite a few oncologists, many oncologists are happy for patients to have HRT alongside tamoxifen, and would certainly prefer that to them stopping the tamoxifen, because tamoxifen blocks the estrogen receptor in the breast, and then hopefully the HRT, the estrogen, can bind to estrogen receptors elsewhere in the body and help to alleviate some of those menopausal symptoms, which will increase adherence, which will hopefully have a beneficial effect on long-term outcomes. I think I'm going to skip through that one just to say that in premenopausal women, if you suppress their estrogen, that this was a trial that wondered whether taking away their estrogen might be associated with even better outcomes. Short answer, it didn't. So even if you suppress their estrogen, women with low risk tumours, it doesn't matter. But lots more side effects. Is there any clinical trial data to support this? Well, again, no. In the HABITS trial, which I briefly mentioned earlier, it reported an increased risk of breast cancer recurrence that was largely restricted just to those women who were using tamoxifen with a hazard ratio of 4.7. But as you can see, the event rate was very small. The confidence interval is very wide. That study had lots of flaws, not least it was discontinued prematurely after just 2.1 years, which increases the risk of a false positive result, i.e. detecting a difference between 2 groups when in fact there isn't one. The Stockholm study, which was a contemporaneous study that was run alongside HABITS in a similar population in Sweden, recruited more women who were using tamoxifen, just over half, and did not demonstrate increased risk of recurrence or breast cancer death. That's all the data we've got, and as I've said earlier, it's limited. So the outcome is that this lady had some vaginal hormones and treatment. She decided to think about the estrogen. So we just started her on some testosterone in the usual way. When I reviewed her in March, her genitourinary symptoms were significantly better. Her hot flushes had reduced. This is just on testosterone alone, nothing else. Subtle improvement in her energy, stamina, brain fog, libido, but she's still got ongoing anxiety. At this point, we're checking her free androgen index. Possibly there's scope for improvement with the testosterone, but she's actually decided to go back to her oncologist and discuss restarting her tamoxifen, but having HRT alongside it. And of course, I think it's worth restarting it, for women that haven't stopped their tamoxifen, or women that are on an aromatase inhibitor. The first thing I might suggest is, well, look, let's switch you over to tamoxifen, because that might improve it. If you've still got symptoms, you can then think about adding estrogen in further down the line. Things change, and you can always change your mind and revisit decisions and go back. Nothing is irreversible. So last two slides, just going to leave you very briefly. So Louise has already mentioned we're working on this consensus statement at the moment, and that will hopefully be available later this year. We're nearly there. But I think these are the two most important statements in the whole work that underpins the essence of what we're trying to do. So when considering hormone replacement after breast cancer, it is important to consider both the risks associated with HRT and the benefits. The risk-based benefit ratio will vary from patient to patient and with time since diagnosis. Risk of recurrence comes down, risk of heart disease, etc. goes up. Individualised care with consideration of the patient's medical history, views, preferences and treatment goals is important when counselling patients, and shared decision-making is key to ensure that individuals can make the right treatment choice that is right for them at the right time. And I think that is it.
Very good. Amazing. It's just always enlightening hearing Sarah, because there's so much information, but she does manage to make it very simple, so I'm very grateful. Thank you, Sarah. So after I saw Bev in the clinic, a few weeks later, I saw another patient with breast cancer. I still wasn't feeling confident because I hadn't reviewed Bev at this time. And this lady came in and she telling me about her symptoms, how awful she was. She was on tamoxifen. And she said, but my oncologist says that I can have HRT. I went, what? Your oncologist? What's his name? I don't know why I said his. It could have been her, but I did say his. She said, oh, this really amazing man called Dr. Tony Branson. Oh, I need to get hold of him. So I phoned Tony and he's like, well, it's all about balancing and looking at, I was like, what? Well, this is amazing, amazing, amazing. So I've pestered him many times over the years. So really grateful that he's going to talk about risk, because Sarah's already alluded to absolute risk versus relative risk. Very, very different, but one's really scary and one's more realistic. And I know even after I had pancreatitis a few years ago, I still wasn't well. And the pancreatitis specialist in a tertiary referral centre, when I was still having recurrent symptoms, said that I was probably depressed and needed some antidepressants because the risk of a cholecystectomy was too high as a slim, fit, middle-aged woman. I went to go and see an upper GI surgeon. He went, oh, your risk is really low. I'm just going to whip it out for you. What does it mean? What does risk mean? And it's really difficult, isn't it? Because I just want to know about me. I didn't care about all the other people that were having cholecystectomies. It's just about me, isn't it, as a patient? So Tony's going to just talk a bit, and I think it's really interesting just for us to take a step back and listen to his very wise words of wisdom. So thanks, Tony, for coming.
Thank you, Louise. I mean, it's said that imitation is the sincerest form of flattery, and actually Sarah and Louise have said a lot of the things I'm going to say. So our talks are a sort of Venn diagram, and I hope you'll find the bits that overlap reinforce your knowledge, and the bits around the outside stimulate your interest. Now, I'm a clinical oncologist, so I treat cancer patients with drugs and radiotherapy, and earlier on in my career, as well as doing breast cancer, which is all I do now, I also treated gynecological cancer and irradiated a lot of women's pelvises. And so I'm probably more responsible than anyone else in this room for premature menopause and menopausal symptoms. So you could see this as a bit of a penance, but I don't really see it like that. So basically, everything we do for people medically is a swap of one set of problems for another. And so when we're talking with them, we need to assess the balance of risk and benefit. And I think that's come across in the things that's been said before. And that's the risk of having the treatment, the risk of not having the treatment, and the different risks of different treatments. Oops. Now, if you think about risk, I've looked in the dictionary, and the risk is the possibility, or if you want to quantify it, probability of suffering harm. Another interesting word is safe. Safe means free from risk, which makes it a pretty useless word, really. It's only useful as a comparative. So less safe or safer, but safe on its own. When people say, is this treatment safe? Truthful answer is always no. Risk is always prospective. It's always looking forward. It is useless saying to somebody to whom something has happened, well, the risk of this happening was very small, or only 1 in 10 people would get this. That doesn't really help people. Our general view of risk takes into account the probability of something happening, which may be believed or it may be actual, and the perceived severity of the harm. And people have different views about that. You can do this with a risk register, and you can compare something that's very likely to happen, but the consequences are very, very minor, and that will have a score, with something that's very unlikely to happen, but the consequences are very severe. Whether that's a reasonable comparison, one can debate. Our assessment of risk is personal, and it's not entirely rational. When you think about seat belts, vaccination, flying. My wife Sally used to be a navigator on stage rallies, steaming through forests at 3-figure speeds, trees, piles of logs. But after a while, she decided that doing this was too risky. That's not her, by the way. That is Eric, who is my number 3 stepson's father-in-law. And when they got married, I was able to say that I've met Eric and it's really nice. He's a great friend and he'll let me do things with him that Sally won't let me do. Anyhow, so I'll give you 3 C words, which are very important in talking to patients and thinking about cancer. Cause, why did I get cancer? Why did my cancer come back? Consequence, what will happen if I do this or do that? Control. Now, the awful thing about cancer is loss of control. A bit of your body has gone and done something you didn't tell it to do. And then choice, what are the things I can do? But there's another very important C word, which is chance. Most people who get cancer, it's bad luck. It's not their fault. It's not something they've done. You know, there is a risk factor for most people getting breast cancer, and that's having 2 X chromosomes. It's not their fault, and most people who have 2 X chromosomes don't get breast cancer. So chance does come into it. We do naively believe we can affect the play of chance. It's a little-known fact, but I'm personally responsible for Damon Hill winning the World Motor Racing Championship and Donald Trump actually not being re-elected in 2020, or it was, because I put money on that happen, on that, well, Jacques Villeneuve winning or Donald Trump thing. So there are various ways we think. We cross our fingers and we do all of these things. We think we can play chance. This is, I think, probably a useful mission statement for all of us. Came from Robert Buckman, who was an excellent oncologist, teacher of communication skills, but also a comedian, sadly no longer with us. But it's no good making people better if they don't feel better. We've had some examples of that today. There's a little bit of talk about the relationship between healthcare professionals and patients, and there are, in my view, 3 models. One is the directive, paternalistic, although now, since the majority of doctors certainly are women, maternalistic, but it's we know best. You come to us with a problem, we tell you what the solution is, you take it, or you can go and do the other thing. Then there's the one in the middle, which is interesting, because it's sort of menu-based. These are the things you could do. You choose. And that seems very empowering, but there is a little bit between the lines which says, you choose. If it all goes horribly wrong, it's your fault. And then the one which I try to adopt and try and practice in my day-to-day work is decision sharing. And that's about two experts in the room, as it were, the treatment and disease expert and the patient expert who knows what matters for them, you know, what their values are and what their fears are. And you try and put those together and you try and make a suitable solution, a suitable treatment for them. It's not completely boundless. I would not share a decision with a patient with an operable breast cancer to get rid of it by the power of positive thought, because in my experience, that doesn't end well. So what matters to breast cancer patients, we've had a bit of this, at the time of diagnosis, most women who told they've got breast cancer actually are worried that they're not going to survive to the end of the week. They think about dying, about losing everything that matters to them. So they want to be cured. And that's all that matters. And most of the treatment decisions about various things are done are made at that time when the patients are very focused on getting rid of the cancer one way or the other. Later on, they then start thinking about, well, I'm getting all these side effects. My life isn't so good. I'm still worried about the cancer coming back, but the two are more balanced. The nearest thing I can come to in personal experience of that is having a high-speed car crash and then walking out of it okay. You think, well, nobody's been killed. Everything's okay. A few days later, I've written the bloody car off. So, you know, one's values and thoughts and what matters to you does change with time. So what's cure? I mean, the official definition of cure is it's that your risk of dying from the disease is the same as a matched population who haven't got it. Well, that doesn't mean much to patients. They might say dying from something else, or you could cure a lot of people who like that, which doesn't help. And of course, some of the things that we've been talking about with respect to the disease is actually, we do make it more probable that they die from something else. So, you know, you have to sort of balance those ones. So in terms of trying to assess the risk of a cancer when a patient's initially diagnosed with an early breast cancer, we have all these things: how big the cancer is, the stage, and whether it's spread to the nose, the biology, its grade, the receptor status. And we've now got a number of genomic tests, Oncotype DX being the one that is principally used. And this is for patients with estrogen receptor positive breast cancer. And they do, I've forgotten this, 29 genes are looked at, and it comes up with what's called a recurrence score. And it does two things. One is it tells you what the risk of distant recurrence is, but it also tells you which of the systemic treatments, chemotherapy or endocrine treatment, actually produces the most benefit. So for the low-risk patients, the great advantage is saying, actually, chemotherapy is going to only give you side effects and it's not going to reduce your risk. The other side of the coin is people sort of think, well, it's good news, you don't have to have chemotherapy, but you'll have these tablets and everything will be fine. So these are bits that come from some letters that have gone to patients from my surgical colleagues. Now, some of them describe a cancer as being estrogen receptor positive. And you might say, well, that doesn't mean a lot to a patient, but it's factually honest. The next thing they say is it's hormone sensitive. Well, what that tells a patient is, oh, it's all about my hormones. And the worst one of all is the one at the bottom. It's driven by hormones. And there are a lot of patients who are very, very worried and scared, principally about estrogen, because of things that are said like this. Now, an estrogen receptor positive cancer is not necessarily affected by estrogen. We treat patients who've got metastatic disease where we can measure we block their estrogen, we give them tamoxifen or we give them aromatase inhibitors. A proportion of them, it won't make a blind bit of difference. The cancer has not read what it said on the tin. So these are not useful things to say. I think estrogen receptor positive is at least factually accurate, and that can stimulate discussion and you can really talk to people. I think the other ones do push people in a particular direction. So we've Sarah's shown NHS Predict, which is quite useful. Adjuvant Online is a similar system, which we don't tend to use very much, and I've mentioned the Oncotype test. So this is, I mean, you've seen several of these, but this one is, you know, somebody with one extra survivor due to hormone therapy. And I see a not insignificant number of women who've been told, you must take these tablets to stop your cancer coming back. And that's what it would do for them. Now, if they're just taking the tablets, they feel fine and it's okay, maybe that's all right. Some who life is a misery, you show them that and they say, I don't know why I'm taking this. Although there are others who would say, and I think Sarah pointed that out, well, I'd be that one. And that's how they feel. This is a much worse cancer. Chemotherapy makes a pretty big difference. Hormone therapy makes a very big difference. But there's still, you know, a moderate number who will not die from cancer, whatever you do. So the next question I come to is, whose risk is it anyway? This is part of the problem. We as medical professions tend to take it on board. You know, you can't do this, it's too risky. It's not our risk. Now, as part of the work I've been doing with this lot, I arranged a survey of members of the United Kingdom Breast Cancer Group, a very good group of people involved in treating breast cancer, clinical oncologists, medical oncologists, surgeons, and we sent this out, and I did this work with Paula Bradley, who's not here today, but who does work with Louise, and we've got some early results. We're going to put it together and present it to the UK BCG, I hope. And basically, there was a whole series of questions. They were largely based about, would you ever agree to a breast cancer patient under your care having HRT? And so this was one who was postmenopausal, had DCIS, had a mastectomy. Now, the point of this is that a quarter of the doctors, and I think these were all doctors who were we sent this to, said no, they wouldn't. If they'd had wide local excision radiotherapy, it's the same, basically, that's the same. If you've got somebody with a very, very low risk invasive cancer, if they were estrogen receptor negative, then still there's a significant number who would say, no, I wouldn't. If you've got a higher risk cancer, that number goes down, the number that they wouldn't goes up. And if it's an early one, again, it's still very low numbers. So we find this quite interesting. And these are the comments, some of them come back. Now, the top comment is one I think I'd subscribe to. It's not black and white, needs discussion with the patient, and it's individual dependent upon the appetite for risk or the view of the patient's risk. And this is the other side of the coin. I would be anxious about them taking it if their absolute risk increased by more than 3%. Now, I wonder how many patients would go along with that. Some would, but most wouldn't, in my opinion. So going back, this has been said already, this is a different load. It hadn't got it's pre the one which Sarah showed. But again, what it tells you is that from randomized controlled trials, and most of them are too small, underpowered and open to criticism, still the increased rate of breast cancer recurrence is small. The HABITS trial, which was closed prematurely because of the increased risk of breast cancer events in the arm that had HRT, so the trial is underpowered because it was closed early. There are a lot of criticisms about many aspects of it, but it's what's there and it's what's quoted by a lot of oncologists who are very reluctant for patients to have HRT. So the problem was an increased risk of breast cancer events. So you might ask, well, what are breast cancer events? They're not Macmillan coffee mornings, I can tell you that. So if you look at it, in the 221 patients who had HRT, there were 39 breast cancer events. The vast majority were local or contralateral recurrence, so new breast cancers or recurrence at the site. And that's disease that is effectively curable. If you look at the control arm, there were only 9. But if you look at the metastatic disease, those are basically the same. And it's metastatic disease which sadly kills people. So what information we have would suggest that the risk of taking HRT for somebody who's had breast cancer is not large. The risk of dying from breast cancer if you take it is almost certainly not there. Again, the confidence is not 100% by any manner of means, but this does give you some grounds on which to discuss things. So the final bits, I'm going to finish early, this is good. Final bits, I would say, is it's important that we remember that we're dealing with individuals, and individuals are all different. They have a breast cancer diagnosis. So I'm somebody who looks after and hopefully helps women and some men who happen to have breast cancer. I'm not treating breast cancer, which happens to be, attached to some tiresome individual who doesn't want to do what I think they should do. Our success should not be judged purely by the fact that the survival from breast cancer has increased enormously since I've been doing it, not due to what I've done, but due to lots of people. And what's important is not so how much time people have in their lives, but how much life they have in their time. So, keeping somebody alive for a long time, if they'd rather be dead, is not a worthwhile thing to do. If they don't happen to survive quite so long, but they have a bloody good time while they're doing it, then that's okay. So the important bit is to explore with every patient what matters most to them. And it is hugely different. And there, I think Sarah showed some bits of, there are, and I've had a patient for whom chemotherapy and Herceptin offered a 29% on the basis of the data that we do have, and the data's fairly strong. 29% increase in her probability of not dying from breast cancer over 10 years, but she didn't want to have it. Now, I must admit I was concerned about that. But what I did with that concern was to see her more than once, just to go through with it. And then she didn't have the treatment, and as far as I'm aware, remains alive. So she actually made a good decision, but it was her decision, and that's the important bit. And it was a decision I could share, because I knew there was another chance that she would either be okay, or if she was not okay, it wouldn't be because she hadn't had the treatment. And the other bit, obviously, is that we need to accept their right to change their minds. And that's nothing, sorry, it's not a sexist thing that women's prerogative or whatever. It's a patient's prerogative. And the final thing to say, I don't know how many of you have read Ben Goldacre's Bad Science. It's worth reading. He's a doctor who's looked very critically at the whole business of how clinical trials are done and what they show and what they don't show, and sometimes how they're made to show things that aren't really there. But his main statement is it's more complicated than you think. So I think that's my lot. There we go. I was going to go and get a bit of paper with the questions on it, although you can...
Okay. Lots of food for thought, really, really important. And, you know, quality of life changing as well as life changing if we get it right for so many people. So I've got a few questions that have come in, but I'm really keen to open up the floor to get you thinking. So if you've got any questions, do you want to just verbalise them, vocalise them so we can get started? Has anyone got any questions? Oh, hang on, Ali's running behind you. There you go, Mary.
I'm not even sure that there's a direct answer to this, to be honest, but at the IMS last year, this kind of presentation was really what I was hoping to see. And it was just, there was such an absence of being willing to even talk about breast cancer association with HRT. And I mean, from your research, you're showing that although a quarter of people are saying, as an oncologist, that they wouldn't consider it, 75% are saying they would. And yet you've got this absolute kind of not even willingness to budge, is how I felt, to have a conversation around it. And I'm not sure, are we seeing that change? Why do you think we are there? I mean, why is there this reluctance to even just consider it when we're faced with patients who are truly suffering?
Yeah, I think it's really great. I mean, I'll come to Tony in a sec. I've been to a lot of menopause conferences, which are great, they're very informative, but they seem to forget about patients. It's about numbers and it's about risk. And as Tony said, you can never have no risk at all. And I think there's a real thing for anything, you can never say no. And I certainly realise that having teenage children, you can never say no. But, you know, it is about discussion, and I feel this very absolute no. It's almost easy in a oncology room because you're not going to see that patient maybe again or not for many times. In general practice, you will see that patient because they'll come back and back and back. And the ones that we see in the clinic are really struggling. And we have to be listening to them. And I think that's the biggest thing that is probably not happening as much, not realising the enormity. And even if we take away HRT, looking at vaginal hormones, it's really important. These poor women, especially on aromatase inhibitors, who are getting recurrent UTIs, really bad vaginal soreness, discomfort, can be really debilitating. And that's not even about systemic HRT. So, Tony.
I think two things. In terms of are things improving, I would say they are a little bit. One of the things I was mentioning earlier on, I mean, I've been a bit unkind possibly to my surgical colleagues by picking up bits from their letters, but I'm now seeing a lot more letters that they're sending to patients who've been started on usually letrozole, but sometimes tamoxifen, which actually say the benefit to you from this in terms of risk reduction is very small, and if you find it is giving you side effects, it would not be unreasonable for you to stop it. Now, I think that is a step forward from how they would be, which is you've got to take this because it's stop your cancer coming back. In terms of vaginal estrogen, again, I mean, our Cancer Alliance breast cancer guidelines state quite explicitly that vaginal estrogen, topical vaginal estrogen, can be used for patients with breast cancer. So there are bits forward. Sarah alluded to, and the whole group of us been doing work to try and put forward some consensus guidelines which take into account the fact that the evidence base is not strong, but there is enough to at least make sensible expert views on what can and can't be done. And I can certainly say that my colleagues are sort of, itching to get hold of those, because they're getting a lot of letters from GPs saying, can I do this, should I do that? And I think they would find something like that very supportive, to be able to say, well, there is a consensus guideline that says, yes, you can, with these provisos. And the main proviso is that the patient should be aware that we cannot say there is no risk. But as I've pointed out, you can't say that about anything, really. And for the majority of patients who are really in a bad way, just being told that, they're given the impression you touch HRT and you will drop down dead from breast cancer within minutes, which is rubbish. But you can see, for somebody who is starting off with a fear level that's moderate, pushes it up and, I've got to do that. Whereas what we're actually trying to do, we can't stop people being frightened of their breast cancer. That's natural and normal, but we cannot enhance or make it worse by explanation.
Thank you very much. Another question here. Here goes microphone.
Hi, I'm Laura, one of the GPs in Buckinghamshire. Do quite a lot of HRT prescribing and have quite a few ladies who are post-breast cancer, and I haven't been brave enough to do anything with them. I do refer them on. But, it's very interesting to hear all of this, and it definitely would be a really good discussion and shared decision-making. And I think for some of my ladies, I'm wondering if there are, any research trials that they would be cared for under. They'd maybe feel like they were being monitored closely if I could point them in that direction, so that if they went on HRT, or monitoring for recurrence and things like that.
I'm not aware of any that are currently being carried out in the UK. And I think it is a difficult one, in that how many of the patients that you see who are significantly symptomatic and for whom HRT would offer benefit would be happy to be involved? They could be involved in a longitudinal study of seeing what happens, so that would be fine, but not to be in a randomized controlled trial where half of them wouldn't get HRT. I think it's a difficult one. It's all about clinical equipoise, really. Can we say that having HRT or not having HRT are broadly the same, and we're going to do a randomized controlled trial to see if one is better than the other? Well, from a symptomatic point of view, no, they're not broadly the same.
Do you want to add anything, Sarah?
No, so I don't think there are any trials ongoing either. So we're keeping, obviously, through the Newson Health Clinic, you see so many patients. I think we've got about 500 patients.
600.
It's 600. So we are keeping a register, and I'm certainly adding mine, and we're talking about sort of joining with other breast cancer menopause specialists, so that we've got a sort of register, and at some point we can, get some observational data out of it. But no, in terms of clinical trials, I don't think there aren't any.
I think the other thing is, as a GP, is like, who do you refer to? That's really difficult, because certainly a lot of, when you talk, it says involve the oncologist or refer to the oncologist, or the BMS will say you can't give vaginal estrogen until you've discussed with an oncologist. So I see a lot of women who've had breast cancer 10, 20 years ago, and they have urinary symptoms of vaginal dryness. I don't actually feel it's fair for the oncologist for me to refer to them to say, am I allowed to prescribe? Because they don't know the patient. Their oncologist is often retired. And then I do think this, I know it sounds really awful, this hierarchy of medicine. Why does an oncologist know more than me about hormones and vaginal estrogen? We've read the same papers, read the same evidence. And, we don't want to overload people. If they're oncologists they've got good relationships with, they're still being reviewed, then of course we'll share information. But I don't often wait for the oncologist to permit me to prescribe, because it's me that's taking the responsibility as an independent practitioner. And I've often had the beauty, very lucky privately, to spend more time with the patient. And it's certainly in the clinic, we then follow them up 2 weeks after to make sure they've had enough information for shared decision-making process. And if they've got any other questions, So they don't feel they have to make that decision then and there. And I think, as Tony said, you can change your mind at any time. And I think that's what we spend a lot of time doing, to say, it's reversible, you can stop, you don't have to start now. And it's often the first review that's the most revealing and important, I think, consultation, when often they do feel so much better. Then you can talk about the longer term benefits or risks. And actually then their mind's often a lot better because they're not so menopausal. So question here.
Sorry, I got the mic. I see quite a few patients who are on either letrozole or tamoxifen, and they are having a lot of side effects. And when I was in the EMS course, one of the lecturers said that letrozole is more to do with the fatigue and joint pains, and tamoxifen is more to do with the vasomotor symptoms. So is it worth me taking down all the details of their symptoms and then write to their oncologist and say they're having these symptoms? Do you think they would benefit from changing their drug to the other one? That's my first question. The other one is I see a lot of women with quite a few women in their family tree who had breast cancer, and they wanted to know whether they could go on HRT. And some people are actually quite keen. They were like, can I go on HRT even if I have to pay for a mammogram every year? Is this something I should be encouraging, having a mammogram privately every year?
So let's answer both questions separately because they're very, very different actually. So the first one, Tony, do you want to answer?
I think, yes, it probably is worth, if you're wanting an answer to specify what the problems are. Although taken overall, the side effect profile of tamoxifen and aromatase inhibitors is different, there's a huge amount of overlap. I used to believe, partly on the basis of the data from the Big 198 study, which is the one comparing tamoxifen and letrozole, and the ATAC study, which is with anastrozole, that basically tamoxifen hardly ever, if ever, produced joint pains. But I've seen quite a few people on tamoxifen where it does seem to have done that. And in terms of hot flushes, tamoxifen is supposed to be much worse than aromatase inhibitors, but that's not universally the case either. So, normally people who are having significant problems of whatever sort with their adjuvant endocrine treatment, the first thing we would normally suggest is stop it. Give them a rest from it 6 weeks or so. You need to say to them that there is not a shred of evidence that doing that increases their risk of the breast cancer coming back. And if you want to be very blunt, as I sometimes am, you say, well, if it did come back, God forbid, it was going to anyhow. And you see some people who stop that, and actually their symptoms are not much improved. And that's maybe because they're underlying menopausal symptoms, which I'm becoming a bit more aware of. You see other people where it's a huge difference. And I always quote a patient who I saw who was having terrible problems with tamoxifen, and I stopped it in 6 weeks and saw her, and she said, oh, I feel the best I've felt for years. And I said, well, I suppose you probably feel you're going to not carry on with the tamoxifen. Oh no, I've got to, I'm much more worried about the cancer coming back. Well, at least she knew what she was bargaining with, as it were. And it might well be that we've studies now showing that 10 years of tamoxifen gives additional benefit over 5. But the extra bit for the next 10 years, the next 5 years really isn't very great. So maybe they might feel, well, actually I've had the 5 and that's pretty good. But people are different.
Thank you. So the other question is about family history of breast cancer. We see a lot of women who have a family history of breast cancer, even just sort of coincidental, because breast cancer, affects 1 in 7 women, it's very common, or those that have got genetic predisposition. There's a lot of women also that have bilateral oophorectomy as a prophylactic operation to reduce their risk of ovarian cancer. Obviously, without your ovaries, you can't get ovarian cancer. But they are also told that they can't have HRT. And even those that have an oophorectomy and bilateral mastectomy are still told often they can't have HRT. So can you just explain?
It's a bit difficult because a significant proportion of people with BRCA gene abnormalities, the breast cancers they get are estrogen progesterone receptor negative. And in fact, one of the ones, people up to 50 who've got triple negative cancers, we're now referring for genetic screening, even if they haven't got a family history. So there's that side. But equally, for people in the past with a family history, there has been a suggestion that they should perhaps be put on tamoxifen prophylactically. So again, we're up in the air with really...
When it comes to HRT, so body identical hormones don't increase risk of breast cancer. So even if someone's got a high background risk for whatever reason, maybe they're overweight or they've got the BRCA gene or they've got a family history, their background risk may be higher, and there's a nice guideline that you can look at in terms of whether they need to be referred to a genetics clinic or, to have that further assessed. But whether they choose to have HRT or not makes no difference as long as you're using body identical hormones. So in the past, it was the synthetic progestins that were linked to a small increased risk of breast cancer. It was, and I think it's important to remember that it was 5 cases of breast cancer per 1,000 women in the WHI compared with 4 in the non-HRT arm. So it wasn't that the women who weren't having HRT weren't getting breast cancer. They were too, but there was 4 in the placebo group and 5 per 1,000 in the HRT group. But we think that was linked to the synthetic progestin that was being used, because in the estrogen-only arm there was a lower risk of breast cancer. And we've got good data with body identical progesterone now, observational data. There's not nearly as much data compared with the synthetic hormones, but we've got good observational data that suggests micronized progesterone and the Mirena coil, in fact, don't increase risk of breast cancer, certainly for up to 5 years. There's only 2 studies that have looked at long-term use of micronized progesterone. One was the Mission study that demonstrated a lower risk of breast cancer in women who used micronized progesterone for about 8 years. And then in the final report of the E3N cohort study, which was published in 2014, there was a slight increased risk of breast cancer in women who were using micronized progesterone for around 6 years. But in that observational study, 57% of the women had also used a synthetic progestin at some point. So you can't possibly say that it was linked to the micronized progesterone or not. You just can't conclude anything. And I suspect body identical progesterone, I don't think will increase the risk of breast cancer when we've got more data. But again,
we don't have it. In an ideal world, everyone that has a bilateral oophorectomy should be considered for a hysterectomy, and then they're estrogen only. And we know from even WHI it's 22% relative risk reduction of breast cancer with estrogen only. So estrogen's the goodie, really.
Yeah.
Really interesting. Lots more questions, I'm sure, but I'm hungry, so you're probably all hungry too. So go out. We've gone over time, but we're coming back here at 1 o'clock, so we can still be out for 4 o'clock. So thank you again.